My presentation is acute abdomen, need for interventional cardiologist. 24-year-old female presented to us with left lumbar region swelling from past 2 weeks and acute abdominal pain from past 1 week. On clinical examination, the swelling was tender, borders are well defined, smooth, not moving with respiration. She had these facial lesions, adenoma sebaceum, facial angioma from past 10 to 12 years, and she had Ashleaf macules, hypomelanotic macule on the forearm from past 2 years, and shagreen patches on the lumbosacral area on the lower back from past 5 years. Clinical examination, vitals were normal. She had mild pallor. Other system examinations were grossly normal. Investigation showed anemia, 7 gram percentage, microcytic hypochromic type. She was transfused with 2 units of packed RBC in the outside hospital and referred to us. ECG and echo grossly normal. Other blood investigations, workup was normal. CT scan abdomen done showed heterogeneously enhancing soft tissue density nodules and multiple fat attenuation foci scattered in bilateral renal cortex, suggestive of renal angiomyolipoma, bilateral. There is a well-defined soft tissue density mass which is abutting the left lower pole of the left kidney, measuring 8.2 into 10.3 into 10.7 centimeters. There is a large hyperdense component within the mass, measuring 8.1 into 6.3 centimeters with a suggestive of active hemorrhage. On post-contrast images, heterogeneous intense enhancement of the mass is noted, with active extravasation of the contrast within the mass, suggestive of active hemorrhage. So these features were suggestive of bilateral renal angiomyolipoma with active hemorrhage in the left kidney. CT scan also showed the sacral hematoma. International Tuberous Sclerosis Complex revised diagnostic criteria for tuberous sclerosis, which was published in 2012 June, showed the major features and minor features. These underlined ones are the features that our patient had: hypomelanotic macules, angiofibromas, shagreen patches, angiomyolipomas, and non-renal hematomas, that was sacral hematoma. So she met the diagnosis, definitive diagnosis based on these criteria. So intervention, selective renal artery embolization. This was a renal angiogram done via right femoral artery axis using 8 French RDC catheter, which showed multiple renal angiomyolipomas in the lower pole of the left kidney with active extravasation of the contrast. This is a still image of the same. Here we can see the renal artery divides into superior and inferior division. This is the anterior division, anterior branch, and the posterior division. So majority of the angiomyolopas are located majority in the lower pole, supplied from the anterior and the posterior division. So, and this was the DSA image of the same. Here at this juncture, our plan was mainly to, if you see carefully, look at the inferior division. There's a branch coming and there's next to bifurcation. So our plan was to actually distal to the branch and proximal to the bifurcation. We wanted to put a coil there. Initially plan was to put gel foam followed by renal coil, gel foam injection. So using an IMA diagnostic catheter, what we did was selectively cannulated the anterior division and the posterior division. You can see in this pictures, this is playing. So selectively cannulated the anterior and the posterior division and we injected gel foam into that. This was the post gel foam image, which is showing majority of the blood vessels are located in the lower pole of the kidney or obliterated. So 10 centimeter into 8 mm Emery renal coil was deployed. Exactly what I was told before, proximal to the bifurcation. After deploying the coil, you can see totally that there's knocked out blood supply to the lower pole of the kidney. This is DSA pre-procedure. It showed significant amount of renal angiomyolipomas, and post-procedure, they're almost knocked out blood supply. There's no blood flow into that. Post-procedure, she had significant abdominal pain for which fentanyl infusion was started with adequate amount of hydration. RFT serum electrolytes were normal. There was no further drop of hemoglobin. So 2 days later, we did a CT abdomen once again to show renal infarct was noted in the lower pole of the left kidney. On post-contrast images, there was no active extravasation of the contrast within the mass. After 2 days, she was clinically better and discharged. Recent follow-up was 1 month back, where she was clinically better. There is a decrease in the size of the abdominal swelling and blood investigations were fairly normal. So follow-up, you can note that there is a decrease in the swelling and ultrasound also confirmed the findings. So take-home message, bilateral renal angiomyolipomas are seen in 70 to 80% cases of tuberous sclerosis. Usually they are asymptomatic, but if they are associated with increased risk of bleeding and life-threatening complication if not treated properly. Renal problems are the second leading cause of premature death in these tuberous sclerosis patients next to neuropsychiatric disorders. So selective renal artery embolization by both embolic agents as well as renal coils are necessary to totally knock out the arterial supply to the angiomyolipomas. Tuberous sclerosis patients have a significant risk of regrowth as well as recurrences even after embolization. So Closer follow-up is required as time to recurrence may vary from months to several years.